clearly, as you saw, that right back in June 18th and 19th, when I started the first this symposium, we used to call it Complex Coronary Cases Symposium, CCS Symposium, CCC Symposium, sorry. And right from that time, I started the Nurse Technology Symposium together. So one day dedicated for last 20 years to really uplift this area, because we know that a physician is one part, but to take to the next level is you need your additional support. And that has been a tremendous this journey. And as you see there, that we, the first time, because now we talk about left main, but I at that time clearly, I would say, advocated that we are going to perform unprotected left main PCI. There was no impella, there was just balloon pump. And we did 3 unprotected left main in those 2 days. And now things have grown to this level. As Beth has shared those our volume stats and the safety record, establishing Mount Sinai Cath Lab as the #1 cath lab in New York. And of course, we have ACC NCDR, which is at the national level. It's in the handbook, which you have with the cath lab brochure. The latest data of 1990, latest data of 2015 and 16 have been incorporated there. With that note, I thanks to both Beth and Antoinette Tolentino for putting this thing together, all this nurse technology, and you see the very rich agenda. We'll ask speakers to be on time so that everybody has on the schedule. And I don't know whether they're going to do it. I can tell you yesterday, because we had 10 minutes lecture, we made it that at 11th minute, the screen will become blank. So you may talk whatever you want, but it's done. So maybe we need to establish the same. So I don't know, they started me already with the 23 minutes. I was supposed to have 30. This introduction time has counted on my side, but that's okay. So what I do is, I decided, and this is again the tradition, that a year before, what are the important advances have been made in the field of interventional cardiology. I put it together and try to show my perspective that how these advances have changed our life as an interventionalist, basically, in the cath lab and so. So these are all, majority of them will be the interventional trials. So Andreas Grundtvig, who was the father of angioplasty, first angioplasty he did in Grundtvig, in Zurich, by Grundtvig, and that really field has mushroomed. And of course, we know his premature death in 1985. He was the one that do one, see one, teach one concept. He used to do all these workshops and seminars, which we have now gone to this level, performing live cases internationally, nationally, live relays and so, but all was started by one person, and that is the Andreas Grundtvig. Now, what I had done is, that his dream was the catheter-based percutaneous treatment of vascular disease. He didn't say coronary only, vascular disease. So they had a vision that not only coronary PCI, also the peripheral, also the valves. That's where we are now in alert, awake patient. And what I added is from SKS, that is the utmost safety, and has been really highlighted. So basically, purpose of these advances to share with you is that they have changed our clinical practice. The few of them, I go one by one. There was one study shown earlier that you give IV beta blocker patient with STEMI, it causes, reduces the infarct size, decreases the heart damage by MRI and CK, decreases the arrhythmia, and that led to a major trial. Actually, the earlier trial was led by Dr. Fuster, then early BAMI. The concept was, what is the ambulance or emergency room? You give 5 milligram of IV metoprolol, and you follow these patients and see what happens. And turns out to be, after the small Metacore scenic small study, in the randomized trial, beta blocker did not show much benefit. It did show little less arrhythmia, but that is it. So overall, it seems to be that beta blocker we use routinely, but it does not have a major impact overall, except as you mentioned that arrhythmia was significantly reduced. The second is the transradial intervention. We all say that intervention gradually increasing in United States using transradial approach compared to the classical femoral approach. Actually, out of USA, the number of transradial is almost 70+%. We are still far behind. We are about 18 to 22%, in acute coronary syndrome about 30%, as based on the ACC-NCDR latest data. So why it is? Because it has shown that overall transradial intervention reduces life, decrease mortality, particularly in patients with acute coronary syndrome and STEMI patients. So besides having lower vascular complication bleeding. So clearly this field has been established. We don't have to say anything about transradial. All programs, including ours, are going, we have make it as a quality matrix now, because we've made a target of 33%. We are not there yet. We are around 22% of intervention done at Mount Sinai at present with a transradial, as I mentioned, with the quality matrix having a target of 33%, because that is the maximum for the ACC-NCDR in United States. Little different than outside, but what are the region are, those are habits and teaching and so on and so forth. So clearly, no question, radial is here to stay. But there are few issues, and of course now the guidelines support the using radial intervention. There are few things have, one of the important things which has come up is that if you are very good at radial, but now you have to do a femoral for some reason, which we know in some percent of cases, 10, 20% of cases, you have to use a femoral. So what has been shown that if you are high radial operator, if you do a femoral case, you're having a more complication. So compared to 2.9, now with the radial people, if going to the femoral, you have a higher vascular complication. Compared to, of course, radial is lower, we understand. But then you still have to do many cases. We know 6 to 10% failure rate with the radial. You still have to go femoral. So it basically shows that this is a paradox, that while the radial is good at itself, but overall, if you see the vascular complication of the femoral goes up. And this actually was shown by earlier studies also, by the Ravel. If you go see that in the high radial group, when you had to go to femoral, your vascular complication much higher compared to lower radial group. So what does that mean? It basically means that, I use the word, the radial fanatics. That's okay. But then at the same time, you cannot forget what is the other route? So you need to have a better training, and so clearly, particularly the young interventionalists who claims themselves as a radial interventionalist, but has to have equal importance of understanding the femoral also. Now, also another negative point of the radial which have been put in the literature is the higher radiation. And even with the time, although radiation in favor of femoral is decreased, but still remains that higher radiation to the patient and higher radiation to the physician in the transradial group. So clearly, these are the two important issues. And the third thing which has come up is the hand dysfunction. So make sure that you don't do radial, particularly person whose livelihood is dependent on the hand. Tennis player who uses the hand for their mechanic work, or maybe doing a PCI. Which I always say that maybe you ask interventionally, they won't ask you to do a PCI from the radial. But key is this hand movement has come to the also with some study showing that in many patients you actually have trouble if you really evaluate, and we have seen cases, and many of them are because of the radial artery occlusion, but not necessarily even without radial artery occlusion, hand movement dysfunction do occur, so we have to be careful. So basically put it together, transradial intervention, decreased mortality, decreased vascular complication, no effect in MI, MACE, stent thrombosis, stroke, exercise bleeding, and one of the most negative point besides crossover of 6 to 10% is the increased radiation exposure. But we just have to be careful about it. Then the CTO, basically our success rate has gone over 90+%. The study published and presented a few years ago, being the expert CTO, Dr. Keeney, the lead enroller and the senior author of the manuscript, just to show that we had done very good job in terms of opening the completely blocked artery at present with our devices and so. And what has also happened, that we grade CTOs based on their complexity, and that is called J-score. And you have higher J-score in the recent cases, but more importantly, you still continue to have a better success. So overall, CTO is good. We should open it, or we are good at opening the CTO. The whole question comes the field, should you open it? Artery is already closed. What is the benefit? Some data in the past have shown that by opening the CTO, you improve mortality. Well, actually, there are some randomized trial now to answer that question. 3 of them, one of them is already has been presented, but the other 2, Euro CTO, actually Decision CTO was presented this year, which will be part of my advances next year. But Explore trial was presented last year. This is a patient with a myocardial infarction, had the CTO recanalized versus CTO left alone in 300 patients and found no difference. So little disheartening, but there was no difference in any major endpoint, but it was short trial. But the mechanistic shows that, yes, you can open CTO, but did not make a difference in terms of decreasing the ventricular size or improving the left ventricular function. So whether will it translate into a better outcome? The Decision CTO data were presented in ACC. Trial was absolutely negative at 3 years. So yes, we are excited about opening CTO in appropriate cases, but truly, by the recent data in the randomized trial, it does not support the concept. Then advances in the imaging for Pci outcome. We have a lot of imaging besides just the angiogram, particularly the IVUS, the OCT, NIRS, although it may just disappear, although it tells you about the yellow plaque, and yellow we know that's is a measure of the instability of the plaque, because higher the yellow content, thin is the cap. And thin cap plaque, which are usually yellow, because all filled of lipid, are the one who ruptures and give rise to acute coronary syndrome. You can measure this with a special device called NIRS infrared spectroscopy. And IVUS, we have criteria, what is the significant plaque, and of course with the OCT, very specific to measure the cap thickness. And that is important because thin cap is the one which causes rupture, thick cap is good, thin. And then lastly the FFR, that gradient across the blockage on IV or intracoronary adenosine, and the number of 0.8 has become the gold standard. So these are the multiple of the imaging studies which have been done in last few years to come up to help interventionists to do the right thing, and particularly the FFR has become the gold standard. Patients who have the low FFR, so even medically treated versus getting the PCI, it turns out to be that once you have a low FFR and medicine alone is not helpful, you need to do PCI. Very, very important from the fractional flow reserve point of view. And that cutoff is 0.8. So less than 0.8, PCI is better. After 0.8, medical therapy is equally good. So now what also we learn now is that FFR baseline, we understood, part of our interventional practice. What if you measure the FFR after your intervention? That's another important thing. And what turns out to be that, yes, that also has the correlation with the outcome. And about 9% of cases, even after your good PCI, you have FFR of less than 0.8. You say, what does that mean? Did my angioplasty fail? No. Angiographically, they were all good. Patients went out of the lab. No major event. But if you follow these patients who have a less than the cutoff, they came up with a 0.87, that clearly that if you have more than 0.86 versus less than 0.86 after PCI, so this is after we are talking about. Pre-cutoff was 0.8. Post is 0.86. So if you have more than 86, you do better. If less than 86, you do worse. So it seems to be that maybe we should incorporate, we rarely do FFR post-PCI, but I think diffuse cases probably makes it a point. Second issue was that whether you can change FFR by combining the imaging and particularly the OCT in the doctor's trial, and showed that yes, by using OCT compared to angiogram, your FFR of more than 0.9, you achieve in majority of cases, 82% versus 64. So yes, by combining your OCT, you improve the FFR value post-procedure, although in the study that there was no difference at 6 months outcome. As you can see here, IVUS versus angiography, the FFR guided, the OCT guided FFR value did not show any outcome. What about the IVUS? Lot of studies have come with the meta-analysis and so last year, one of them being randomized trial in the long Zions cases, IVUS versus angiography guided, showed that you have lower event rate with the IVUS. So it seems to be that IVUS is winning in having some outcome, but really we need to have long-term outcome as shown this meta-analysis, again positive. What about you compare all three, which is the Illumin 3, that OCT, IVUS and angiography, Does it change the outcome or your stent expansion? In this trial, all three were randomized, about 150 patients in each arm, clear criteria with the OCT. OCT is kind of a new kid on the block, more specific than IVUS. And what basically they found by using OCT, IVUS, or angiography, overall your stent, the cross-sectional area, mean stent area basically, was no difference. Why? Because angiography, we got very good at it. We post-dilate the stents and usually they're fine. So the primary endpoint of the study, that OCT makes difference, they were not met. And of course, there was definitely some improvement occur that in the OCT group, you have a less dissection, less malopposition, and so. So some softer endpoint, but not the primary. So investigators have already started a randomized trial, OCT-guided PCI versus angiography-guided PCI, and I wish them good luck, if really, because so far, OCT has not come into the clinical practice as shown. And the overall outcome you see at 30 days was no different in three groups. So OCT actually had a few higher complications. In the imaging, the best work is done from Mount Sinai by Dr. Keeney and the team. Basically, it was the relationship, yellow 2, of the serial changes in the plaque morphology of obstructive non-culprit lesion to HDL efflux, inflammation, and transcriptal perturbation in response to high-dose statin therapy. It's basically translational research, combining the cath lab work with your basic science, and particularly with the whole premise is that patients who some respond, some don't respond to statins. Because how many times we have patients who are on statins still come with acute coronary syndrome? Majority of them. So at present, when patients come to the cath lab, they're already on statin. But why they break through? So maybe it's some genetic issues, some biomarkers, and this was the whole focus of this study with the yellow 2, and very complex study in the sense, and Anu has done that before in a yellow 1, that 85 patients had a baseline non-culprit vessel imaging, got a rosuvastatin 40 milligram daily for 8 to 12 weeks, came back, again had before the PCI, angiogram OCT, NIRS, and IVUS. Very extensive, very deliberate, but time-consuming study, and then at the same time, do the biomarker, combined with the genetics. And this is basically these are the combination of you can see OCT and IVUS and the infrared X spectroscopy basically showed that high-dose statin decreased the LDL cholesterol, which we knew from baseline. But what we learned is what the premise was, that how does the statin works? It decreases LDL, yes. But what else? Most important being the cap thickness, that make your fibrous cap thicker, 100 versus 109 micron. And of course, the thin cap decreases, and so also the macrophage. So basically, the concept was, which we know, first time has been shown by the imaging. And the second issue was, what do we combine with the gene expression? And there were 6 genes were identified, very complex plot, if anybody can figure that out. The nice colors and so, but it's just to say that this field is evolving in the sense that maybe with this translational biomarker to predict patients' response to therapy. Because why? If the statin doesn't work, we have a lot of other treatment now. We have PCSK, we will have ApoA1 Milano, which is the HDL, the synthetic HDL. So many others, the work being done in this field with Dr. Keeney, and we are proud of her, that a lot of imaging data which are positive have come up from our lab. The advances in BMS versus DES, people always talk about. BMS is better versus DES. We have the largest trial called NORSTENT of 10,000 plus patient, 6-year follow-up, showing that the DES does not have higher MI rate or stent thrombosis, rather lower stent thrombosis compared to BMS. And of course, the lower TLR. Very, very important point. So basically, we learned that no role of BMS at present, even if a patient needs surgery, maybe if they had to done acutely different, but even after 1 month, you can put a DES and stop the antiplatelet therapy and so forth now. So DES is our default approach in all intervention, particularly the bleeding risk patient. You put a drug-coated stent rather than polymer free. So it's much easier compared to bare metal. So everywhere the bare metal has lost. Then what about the depth duration post PCI? We know that in the past we used to worry about thrombosis. Then we learned you give long term of dual antiplatelet therapy post stent, you have more bleeding. Now we actually, because of the better stent platform, the guidelines have changed, because longer you continue, more bleeding occurs. And many trials have been done, which except one trial overall showed that the short duration is equally good compared to the long duration, except the study called DAPT, where the long duration trial, which is in the 30-day red bar, is lower than the yellow bar. So clearly the one trial only, but majority of other trials showed negative. So then the guidelines were published and basically said, very simple, if you have stable CAD, you need antiplatelet therapy for 6 months. Your acute coronary syndrome, you continue for 1 year. In rare cases, you go beyond. So clearly the 6 months has become in routine cases. Now we are going down less than 6 months. What about 3 months? There is a trial showed that even 3 months is better than your routine 12 months. The red bar always in all the segments lower than the blue, which is the 12 months and red being a 3 months. And this field is evolving. Many trials are happening at present with the evolve. And the one important issue also is maybe we don't need aspirin, particularly if you're using ticagrelor. 2 trials, global leaders, and the Twilight with Roxana Maran here from Sinai. Large number of patients will answer the question, maybe you don't need aspirin. The bleeding long-term happens in these patients maybe from aspirin, and so that should be discontinued. So basically, now 6 months is a routine. Longer you can give patients with acute coronary syndrome and diabetics and multiple stents and so. Then what about the triple therapy? Patients who got the stent but needs anticoagulation. We used to give warfarin in the past, but now the newer agent, what to do? And most common group of those patients is atrial fibrillation. We knew with that earlier that if you get a combination of the triple therapy, warfarin, clopidogrel and aspirin, event rate 1 year was 45%. If you take away the aspirin, warfarin, clopidogrel goes down to 19%. But that was the warfarin. People don't want to use warfarin now. So what about the newer agent? And that was the pioneer AFib trial, which compared Xarelto, basically, our rivaroxaban, 15 and 75 milligram, compared to all three of the agent versus routinely what with 3 we use, the warfarin, clopidogrel, aspirin, and basically found the best combination is rivaroxaban and clopidogrel. Have a lowest bleeding compared to, and there was no difference in the MACE point of view. So seems to be Xarelto 15 milligram and Plavix 75 milligram is the what we use now in these patients with AFib and requiring triple therapy or indicate for triple therapy, but dual therapy of rivaroxaban and clopidogrel is the best. This field is still trying to get other agents. This is the dabigatran. And of course, the another trial, Augustus with apixaban, will know more about it. Then, what about the BVS implantation? BVS had the concept that it will get absorbed over time, which makes sense. The studies have shown that compared to the metal stent, the BVS gets absorbed, the struts disappear slowly at 5 years, you have the vessel without the cage. So makes sense, but then let's put it to the trial. Compare the BVS with the regular metal Zions stent and basically showed, which is a big, shocking news, that BVS now have a higher event rate compared to your regular metal stent at 3 years. Totally different than what was the premise of the BVS. And particularly, look at the 6% MI rate versus 1, and more importantly, thrombosis, 3% versus 0. You say, how can that happen? It turns out to be that at 2 to 3 years, when the struts of the BVS start dissolving, causing the thrombosis, and if you are not taking the dual antiplatelet therapy, you are in trouble. And so this is the most common mechanism. Struts are being resolved, but they are hanging in the vessel and cause thrombosis and so. So then we came up that maybe you should change the optimization called PSP, prepare the lesion, size appropriately, and post-dilate. And that actually have shown that you use a specific protocol versus regular from 3% goes down to 1% stent thrombosis. Makes sense, but this field actually has gone quite a bit. Absorb 3 trial, which was done, we'll have a 2-year data this year, also showed double stent thrombosis. And particularly the problem, majority in the small vessel, in the less than 2.25 that led the FDA alert this year that small vessel probably don't use Absorb. It's very important. So clearly, so now question is, when do we use Absorb? Who are the ideal candidate? I used to teach some, but for the time being, I would say poise. We don't use it. In last 5.5 months, we have used one case only, and that is one of the nurse from upstate wanted. She's 47-year-old, had a non-QA of the circumflex, came just for this specific purpose. So very important. So the patient came for that purpose, but otherwise, till we know, although there are this field, we had no problem with the patients, but the newer stent design which will come into the market, we'll see more and more. So then, extending the indication for the tower, the two group, we know it lasts very well. Intermediate risk group, the trial partner 2A, which showed overall benefit of the tower below 2 years of the mortality and disabling stroke compared to the surgery, and transfemoral approach actually the better than surgery with a p-value of 0.05. And overall has become now a standard of treatment. In the registry data, actually, they even have a better outcome, the blue being the tower and yellow being the surgery. So seems to be the tower for intermediate risk is the way to go, and that extended our indication of the tower. The CERT-AVI trial, which was your part, was presented this year, had the similar data. So one of the important issues remained with the stroke with the tower, and basically various devices have been studied. And one of the trial, the device, which is the Sentinel, very complex filter, and it showed basically that by using filter, you decrease the brain stem, the MRI detected lesions, and overall stroke rate from 9% to 5.6%. So led to FDA approval, and we are using at Sinai this device now. So clearly, the only one remaining is the low risk. Trials are ongoing at present in the severe aortic stenosis to answer the both SAPIEN as well as EVOLUTE. Whether it will be as good as surgery need to be seen. So then, most important advancement of last year was the left main revascularization, and we know that left main can go for PCI or CABG. Each have their advantages and disadvantages. Few of the trials have done in the past, but most important, we learned data from the syntax that if your syntax score is less than 32, that is each lesion we calculate, and then you go with the score, and if less than 32, you actually do better. With the PCI, of course, it's a more complex lesion, you do worse than the CABG. That led to a trial called Excel, 1900 patient trial with a syntax score of less than 32, and it showed basically that identical outcomes. And that's a very, very reassuring. So that led to a 3-year follow-up, that CABG versus Zion's PCI, exactly identical outcome as shown in the individual endpoints also. The second trial, Noble, which was done with a more primitive stent, did show bad outcome or worse outcome compared to CABG in the PCI group, but to me it was the stent design change which really created a problem. So most important is that you use a state-of-the-art stent, you have had good results with the Zion's compared to the CABG in this left main. So at least it has come to our appropriate use criteria, which was not there even a few years ago. The latest 3 months ago, they have included left main also in some selected cases as may be indicated. So now only question is the major, is it going to change the guidelines? Official guidelines, we need to wait, and whether the left main PCI also become as good as CABG from the recommendation point of view. So these are our top 10 advances, and if I put it together, and that what we learned, for 2016, Absorb BVS, beta blocker, OCT, CTO, PCI, we didn't have any positive outcomes. Short depth, transradial, FFR post PCI, IVUS in PCI, of course we have plus data. Then Pioneer AFib, the newer DES, Yellow 2, Sentinel, cerebral protection, yes. And of course, the real advances, tower in intermediate risk and unprotected left main PCI has really made us as a better interventionalist, and so much so that if I give you data of 5 years, of course, Beth showed a little glimpse of our the few years ago, which was shown by the New York State. But just to say consistently, the data of less than 1% overall complication, combining death, in-hospital death, urgent cabbage, CVA, large myocardial infarction has been less than 1%. And this credit goes to, of course, my attendings, the cath lab attendings, but equally the cath lab staff, the other telemetry, CCU staff, and everyone who has really they all work as a team. And that was Beth's, the opening lecture was that you can succeed, but you need to the top. You get to the top, you have to take everybody together. Everybody has to work with the same thought process, with the common goal, making patients improve and have a great, good, long-term prognosis and better quality of life. Thank you very much.